very important to us in this field because it shows the interest and the importance you attach to this subject. For today, like Dr. Mkembo mentioned, we are commemorating, we are having this presentation in commemoration of the World Asthma Day. And the theme for this year was Asthma Care for All. For today, I'm only going to restrict myself to the children and adolescents, but it doesn't mean that the adults do not matter. And like mentioned earlier, I'm going to share largely practical aspects. So a number of people sent in questions. Some of them are related to chronic care. Some of them may be outside today's discussion. And I'm just hoping that maybe we may get another time when we can go through them. But for today, it's just about the basics. Imagining somebody seated in Buwenge Health Center 4 or Magamaga Health Center 3 or wherever I come from. How can you approach the management of somebody who comes in with asthma symptoms? Can I confirm, can somebody confirm if they can see my slides and can hear me clearly?
Yes, we are seeing the slides and we can hear you clearly.
Thank you so much. So
yes, Doctor, you move your slides faster.
Okay.
Okay.
Yeah, I'm saying that key issues to remember as we go through this presentation, that asthma exacerbations, which we also sometimes call attacks, are an emergency. Because they're an emergency, your primary goal as a clinician or somebody who is attending to this child or adolescent should be to actually save life. So we should be looking out for those things that are going to help somebody get the life back, so to speak. So we'll start with the basics. Asthma is about the lungs. So for a normal lung, that structure which you see on the right side, we have the bronchi or the bronchioles. And at the end of each bronchiole, we have what we call the alveoli or the air sacs. And then there are blood vessels, both the veins and the arteries around that. We'll appreciate why I brought that picture later as we go through the discussion. But just to mention that if somebody is having an asthma attack, the problem is within the airway or what we call the bronchi. But because it's in the bronchi, the neighboring structures or the related structures come into play. So let's look at the asthmatic airway. The problem with anybody who has asthma is that they have chronic inflammation. And because they have that chronic inflammation, they have a tendency to overreact to things within the environment, which people who do not have asthma do not react to. And when you're talking about children and adolescents, the common triggers or agents that would throw somebody into an attack include viral upper respiratory tract infections. When they get a common cold, they have a runny nose, they have coryza, like we call it sometimes, they could easily get an asthma attack. If they're exposed to air pollutants, this could include tobacco smoke, smoke from cooking, burning rubbish, whether around the health center or in homes, smoke from candles, from perfumes, and other things. Sometimes people react to certain components in food. When they have food allergies, they could actually have an attack. Very important to note that if somebody is already on asthma medications and they come to you with an attack, ask yourself, are they adhering to the controller medications that they're supposed to be taking every day? Sometimes we see a lot of attacks during certain seasons. For example, this current season where we have a lot of rains and the trigger there is cold. Sometimes if it's windy because of the dust. Sometimes if we have a lot of flowering plants and around our homes or health facilities, and that's because of pollen. Some people, when they get attacks when the extremes of emotions, extreme anger or excitement could trigger an attack. For some people, it is exercise, but we also know that extreme stress, like commonly happens in school children at certain times of the term, actually can trigger an attack. So these things are important to think about as you look at somebody who has presented to you with an attack. So what happens during an exacerbation? Again, I want to say that for you to figure out how to approach this patient, you need to figure out that airway, that tube, what is happening to it, so that you can do the correct things to save that person's life. So during an exacerbation, that person has what I would call acute on chronic inflammation. I mentioned earlier that asthmatics have chronic inflammation, but something comes in, maybe cold, maybe smoke, and it makes the inflammation suddenly worse. And as a result, you find that that patient or the airways get swollen, or what we call edema. They are reddened. They produce a lot of mucus. And at the same time, there are bronchospasms. So this picture shows what a normal airway looks like. It's wide and there is no mucus. It's the air sacs are okay. But when you look at the right side, that's what we call an irritated airway as a response to the trigger, and it has become narrower. And if you're able to visualize it physically, you would see a lot of mucus. So to just put it more clearly here, and what I wanted to show in this particular slide is for you to look at the normal bronchiole, specifically the muscles. They are okay, but when somebody has an asthmatic attack, the bronchial muscles, those muscles that are surrounding the bronchioles, they go into spasms or they contract and actually tighten the bronchiole, and that also adds on to the obstruction that person may be having in addition to the inflammation. So as you think through somebody who is coming to you with an attack, just know that they can't breathe, their airway has narrowed, and so your duty is to find a way of making that airway wider so that they can breathe and meet their oxygen needs. So somebody comes to you, what are the things you should be looking at? History taking is critical. It's going to help you find a way of managing this patient. So many times they may present with cough, difficulty in breathing, they may say chest pain or tightness. If they're older, there may be wheezing. What I want to emphasize here that a patient may have one or more of the above signs and symptoms. Many times we see people having one symptom, for example, an irritating cough, and people think that is not an asthma attack. It is true that cough alone can be an attack, and when you respond properly, that cough actually goes away. In addition, you need to ask timing of onset and cause. Was it cold? Did they get exposed to air pollution? What are those things that may have led to the attack? The severity of the symptoms. Is it that by the time they come to you, they can't talk, they can't walk, they can't go up the hill? It kind of still tells you very quickly, even before you examine, how sick the patient is. Look out or ask about the signs of anaphylaxis. For example, do they have an itchy skin, eyes swollen? People with asthma tend to have other allergies, and this can be a good pointer for you that something wrong is going on. Also ask about the medication they have used, either previously or during the current episode, because sometimes by the time they come to you, they have used certain medications, and this may change your course of management depending on what they have taken. So when you examine, again, remember, as you examine, the goal is to save the life. So as you do your examination, focus on the life-saving signs first. So you want to look at the general condition of the patient, especially the level of consciousness, the posture. Many children, when they have a severe attack, they will not want to lie down. However much you want to force them to lie down for an examination, they would prefer to sit, and actually sometimes they lean forward. Sometimes they don't want to talk. They are not being bad children. They are not being, stubborn. They're just not able to talk because of the attack. Do the basics, the ABCD, check the airway, the breathing, the circulation. Look out for cyanosis. These days, pulse oximetry has become more common. Quickly do pulse oximetry and find out if they need oxygen urgently. Count the respiratory rate. Find out if they have an audible wheeze. Quickly undress the child or tell the mother or caregiver to undress the child. Look for signs of respiratory distress. Look at the lower chest margin to see if it's going in when the child is breathing in, if they have intercostal recessions. These are all important signs because they tell you how severe the problem is. Measure the pulse rate. If you're able, do the blood pressure. And for some centers where you have the instrument we call the peak expiratory flow meter, please use it. It can quickly tell you how bad the obstruction is. All these are things you can do very quickly, and they can be extremely helpful for you to monitor the progress of that patient. As you realize, I focused on a few things, not the usual exam we go through for every patient who comes in. Again, it is because we are focusing on really saving a life. So we do what is really necessary at that point in time. So after you've gone through that examination, find out what is the level of severity of this attack. It's extremely important because then the response depends on the level of severity in terms of medication, but even in terms of whether you're going to refer, because you have to find out, can I manage this patient in my health facility, or I cannot manage, I need to refer. So you need to determine whether this attack is mild, moderate, severe, or life-threatening, or sometimes we call it near death. I want to emphasize that the updated guidelines or the updated information, we no longer have diagnosis of status asthmaticus. It's an outdated term. So we use just those 4 degrees of severity. So I've gone through this before. I'm not going to go through every sign, but what I want to emphasize when you're grading the severity, don't first find out if the child has mild disease, because by the time you find out if they have life-threatening, it may be too late. So when you're grading and you're putting your signs and symptoms together, find out, ask yourself, do they have life-threatening asthma? If no, then you ask the next question, severity. Do they have severe asthma? Do they have moderate or mild? In other words, start looking out for the life-threatening asthma, moving downwards to the mild. And these are just examples of the signs you need to put together to find out whether this child has life-threatening asthma, severe asthma, moderate, or mild. Since I'm going to share these slides, and in the interest of time and the discussion coming ahead, I'm not going to go through each one of them. But as you can see, these are signs that we actually talked about when we are talking about the assessment of the patient. So I'll not go through them. These ones we can read and understand by ourselves. So after you have graded the severity of the attack, you're thinking about giving treatment. Again, remember, primary goal is to save lives. So focus on what is going to kill the patient. Focus on life-threatening problems. And the reason why I emphasize this, it's not uncommon when an asthmatic comes in an attack and we are looking for the cannula, it's not in the health facility, then you send the mother to go and buy. The nearest pharmacy is 2 kilometers away. Again, let's focus on things that are going to save the life. And when it's an asthma attack, because I said the problem is airway narrowing or the obstruction, we know that that person is not able to take in enough oxygen. So if you measured your peripheral oxygen saturation and it is low, please give oxygen if you have it at the health facility. And then the next point you want to do is to relieve the obstruction. Those are 2 critical things. Give oxygen if needed. If the oxygen saturation are okay, make sure you relieve the obstruction. Then the patient can breathe better, they can continue getting enough oxygen, and you'll have saved a life. Please do not look for a cannula to give hydrocortisone, to give ceftriaxone, to give, those ones can come later as indicated. The primary goal is to save a life. So look at oxygen saturation, relieve the obstruction, then that gives you time to do more assessment, and then you can continue with the rest of the medication. So the next point, after you've relieved the obstruction or you've given the treatment, relieve the obstruction, and if the patient needs oxygen, they're already on oxygen, then you want to prevent the progression of the exacerbation. And because the cause of the exacerbation is the acute inflammation that I talked about, the way we manage this kind of inflammation in asthma is to give corticosteroids. So that one helps to prevent the further progression of the inflammation. Otherwise, you'll keep relieving the obstruction, and then inflammation is ongoing. So you'll keep in that cycle of giving no relievers, but when you're not preventing what in the first place brought the obstruction. So we give corticosteroids. And then the other thing, which is also critical, if you found out the trigger, remove or withdraw from whatever the trigger was. And a few examples which we have in our health facilities, and I've seen this before, you may be managing an asthma exacerbation when there is burning of rubbish just outside the ward. Certainly, you may not get a breakthrough. Or when it is extremely cold, you've exposed the patient, it is raining, and the cold is ongoing. So please try to look out wherever you are, whatever environment you're in, is there something that could make this exacerbation worse? And then deal with it. So I'll quickly move to medication. So we've gone through the grading of the severity. We've decided that we are going to relieve the obstruction. Maybe the patient is already on oxygen. We've started there. And if we want to start the corticosteroids. So what exact medicines are we going to give? And the medicines are categorized into two. There are those which we call relievers. And the reason why we call them relievers, it is because they are the ones that relieve the obstruction. That is critical. And the best medicine to relieve the obstruction is the short-acting beta agonists. The quickest example I can give, or the most common medicine we use, is salbutamol. So salbutamol, when given inhaled, it quickly relieves that obstruction because it has a very quick onset of action. Many times, I'll give an example. If you have an adolescent and, for example, you want to give 6 puffs, by the 6th puff, they will tell you they're actually feeling better than they were feeling when they first started with a first or second puff. It is that fast. And that's why the preferred mode of relieving an obstruction is using the inhaled medicines, not the IV, not the oral, because those ones take a much longer time, but also they're associated with many side effects. So the preferred route of relieving an obstruction is using inhaled salbutamol. Now, for somebody who has mild, moderate, and in a few cases when they have severe, we prefer to use the metered dose inhaler. So that is when you use the inhaler with a spacer. And we give 4 to 10 puffs of the inhaled medicine every 15 to 20 minutes. I'm going to repeat this. If somebody comes in with an asthma attack, which is mild or moderate, a few cases of severe depending on where you are, but basically for those who are mild and moderate, the first line or the priority treatment is to use a metered dose inhaler using a space. It is because when somebody is having an attack, they are breathless, they are coughing, they have chest pain. Even if they're adults, it's difficult for them to coordinate the technique of inhaling the medicine. And so many times when you put the inhaler directly into the mouth, most of the medicine will end there. You will not have enough dose reaching the airways, and then people will quickly declare, whether health worker or the patient, that the inhalers are not working. So it's extremely important that you use a method which is going to make sure that that puff reaches the lungs, which is the airways where it is required. So we give 4 to 10 puffs, depending on the age group. Make sure you give it every 15 to 20 minutes. Again, I want to emphasize this because many times we get patients who say, I took 4 puffs and then they wait another 12 hours. It's very difficult to get out of the attack unless if you give it every 15 to 20 minutes and you make sure that you give the 3 doses in the first 1 hour. For patients who have life-threatening asthma, or in cases maybe where you do not have a metered dose inhaler in the health facility, that's when you go for nebulized salbutamol. So it's not always that the first thing you reach out to is a nebulizer. If you have an inhaler, please use that. But if you don't have it, or you have somebody who has life-threatening asthma, then you go to the nebulized salbutamol. If a child is less than 5 years, give 2.5 milligrams in 5 mils of normal saline, nebulize. In older children, we go to 5 milligrams. So it is very important, again, as you nebulize, you target to give every round of nebulizer every 15 to 20 minutes. And so that means your nebulizer must be working well. There are some nebulizers that take 30 minutes just to deliver one single dose. You will not get a breakthrough to relieve that exacerbation. So your nebulizer should be working well and target to give 3 doses of the nebulized medication within an hour, meaning that each dose is 15 to 20 minutes apart. So just to have some visual about what the spacers look like. So we have 2 or 3 types of spacers, or 2 categories of spacers. There are those that are scientifically made. They're designed as spacers. They're expensive. They are not available in most of our health facilities. So you may not get it. You may not have it in your health facility, but there are alternatives. So as you can see in that picture, you can use a mineral water bottle and make a spacer out of it. That can be very helpful. I'll show you how they are used. Or you can have a plastic cup. Again, you can design it so that it can accommodate an inhaler, and you use the opposite end to put on the nose and the mouth of the patient. It is much better than using the inhaler directly into the mouth. So these are the things I was talking about. Where there is no spacer in your health facility, you can make one. These things are cheap, they're readily available. Sometimes you drink the water and then we throw them away. I think I would encourage us to try and keep some of these bottles. They will come in extremely handy when you have an exacerbation and you don't have a spacer, or you have a few spacers, but you have more patients who need them. Thinking about these plastic cups and bottles, the best one is the one which has less folds. The more folds there are, the likelihood that some of the medicine will stick in those folds and therefore will not be available for inhalation. So the more smooth the bottle is, the better. Again, please try to make these spacers within your health facilities. They come in so handy in times of need. So then, let's imagine you have a spacer. We have 2 categories of spacers, or 2 types of spacer. There is one which we call a spacer with a face mask, designed in such a way that the mask covers both the mouth and the nose. And then you push the medicine into the spacer. And for children who are less than 5 years, you just let them breathe normally. But we know that every time they breathe in, they will pull the medicine out of the spacer right into the lungs, because there is nowhere else that breath will go apart from the lungs. And the medicine will get deposited there and relieve the obstruction. For children who are older than 5 years, we use what we call a spacer with a mouthpiece, as you can see in that picture. So if you have, for example, the mineral water bottle and you cut it at the bottom, so this other end which you use for drinking water is the one which you fix in the mouth, and then the inhaler is fixed at the bottom, and then you push, and then you tell that child, because they're a little older, to try and take in slow, deep breaths. And we know that every time they take in a breath, they will pull the medicine from the spacer chamber into the lungs, and they will be relieved. In fact, you'll find that for these older children, by the time you do the 3rd round of the inhaler, it is much easier than it was at the first time, because there has been significant relief of the obstruction. So supposing you've done that, you've given the nebulizer or the inhaler every 15 to 20 minutes, it is the right dose, but the child is not improving as you expect. how do you know that this child is not improving? You need to check certain parameters quickly again. If the child had low oxygen saturation, keep checking using the pulse oximeter to find out if the oxygen saturation is improving. And I want to emphasize, you don't have to wait to deliver the 3 doses before you check on the patient. The best way is after the first dose, check and see, are we getting better? After the second dose, check. Otherwise, if the child is not getting better and you wait for the whole 1 hour, you'll have lost a lot of time in trying to save that life. So imagine that your child is not registering the improvement that you expect. What do you do next? So step 2 is for you to again give salbutamol, but this time you combine it with ipratropium bromide. And most of the medicines we have here, it's either a combination or they are separate, but it's commonly in a solution form. And that's when the nebulizer then comes in. The dose is clearly stated there: for less than 2 years, 0.125 milligrams of the ipratropium bromide. And then for those ones who are more than 2 years, is 0.25 milligrams per dose. So again, give it every 20 minutes for about 1 to 2 hours. And then after that, you can give every 4 to 6 hours. As you do that, I know as doctors, we prescribe and write there every 30 minutes times 3 doses, and we come back maybe 4 hours later. It's very important that we keep monitoring these patients to find out the response, to decide on the next course of action, or to find out if actually things are working well. And I want to mention that sometimes the reason why the patient may not be improving is because either the dose is not correct, or it's not being given correctly, meaning that it's not reaching the lungs. For the nebulizers, please check those tubes, check if it's running well. Sometimes it may be making the noise, but when the aerosols that we want the patient to breathe in are not being generated. So check the equipment or the devices to find out if they're working properly. The alternative to salbutamol and ipratropium bromide is where you give salbutamol and atropine. Again, that's the dose of the atropine. In other words, if you don't have ipratropium bromide, but you have atropine in the health facility, you have a nebulizing solution for salbutamol, you can combine those 2 and then give the child. All these ones are relievers. We are still talking about things that are going to relieve the obstruction. So supposing you've done everything right, you've had step 2, everything is correct, but the child is not getting better. Then you can move to step 3. So step 3 is where you give IV magnesium sulfate. Now, I know we have this magnesium sulfate in our health facilities. I know it's a common drug in obstetrics, but by the time somebody needs IV magnesium sulfate, probably they are not the kind of patients you want to manage at Health Center 3, or maybe some Health Center 4s. It might be the kind of patient who you would have already prepared to refer to the highest level of care, where there is more infrastructure and human resource to be able to manage this patient. And so if you're in a hospital, you have IV magnesium sulfate, then you can give 25 to 50 milligrams per kg per dose. And we usually give a maximum of 2 doses in a day, meaning every 12 hours. Maximum should be 2 grams. From the few patients where I have had to go to magnesium sulfate, usually after the first dose, they experience so much relief that you quickly revert back to salbutamol inhaler. In other words, what I'm trying to say, if somebody gets relief with magnesium sulfate, their oxygen saturation, the respiratory rate has gone down, they can now talk, or they're asking for something to eat. You don't have to continue with magnesium sulfate. You have rescued, then you can go back to the more user-friendly medications of salbutamol inhaler or the combination, depending on the condition of the patient. Step 4 is when we can use IV aminophylline. And the recommendation, and it's a strong recommendation, this is really reserved for patients who are in intensive care units. IV aminophylline has a very narrow therapeutic margin. Many times it's difficult to titrate the dose, especially for children. And so with the side effects that are associated with it, it is best given when you can monitor the levels, but you can also monitor the parameters of the heart, like the heart rate. People could quickly get into arrhythmias, but you won't recognize that unless you're on continuous monitoring. That's why the recommendation is only for those patients who actually need IV, rather ICU care. Please avoid sedatives. I've seen prescriptions, and especially children who come in when they're having cough every now and then, irritating cough. Some healthcare workers say, let's give a sedative so that they can sleep and stop coughing. That irritating cough, the lungs are telling you that there is an obstruction, there is a severe irritation. Please give me a reliever so that I can get better. Avoid giving sedatives. So steroids, like I mentioned earlier, relieve the obstruction. Make sure you stop the progression of the inflammation. And this is when the steroids come in. The preferred steroid, at least on the Ugandan market, is prednisolone. And it is oral. So we give oral prednisolone 1 to 2 milligrams per kg per day. A maximum of 40 milligrams for children who are more than 5 years. For the under 5s, we give a maximum of 20 milligrams. In other words, take the weight of the child, multiply by 1 or 2, and find out what is the weight that, what is the number of tablets you need to give that to the patient. There is no need to taper the dose if you give for 3 to 5 days. If the patient is unable to take orally, only and only when they're unable to take orally, then you can give hydrocortisone. But for all patients who are able to take orally, prednisolone is a cheap medication. It's readily available in most of our health facilities. Please use the oral route because research has proven that the oral route is as good as the IV route. It's not that all IV medications are faster than the oral medications, but it's also much easier to give, much quicker to give, and it's less expensive. Hydrocortisone involves the cannula, the skill, the risk of infections, and so many other things. So please give the oral prednisolone at that dose to minimize or to cut off the progression of the inflammation. So what complications? What could happen to somebody who has that acute attack? So I bring back this picture to kind of figure out what could go wrong. Remember, I said the bronchioles are obstructed. They are narrow. So when the bronchioles are narrow, that means that person is not taking in enough oxygen. They're having difficulty in breathing. Their work of breathing has actually increased. So for some of the patients, unless they are rescued quickly, they could actually experience respiratory failure or indeed arrest. Hypoxemia with hypoxic ischemic sinus injury. So the reduced oxygen supply through the lungs eventually affects other body organs, including the heart, but also the central nervous system, and it causes injury to the central nervous system. So that's why I emphasize that it's important to relieve the obstruction so that the patient is able to get enough oxygen, because this really can affect other body organs. They can get a pneumothorax. So what happens when somebody gets the narrowing of those bronchioles? Every time they breathe in, it is much harder to breathe out. So air gets retained in those air sacs. So they keep ballooning and ballooning, and sometimes reach an extent of bursting and release air into the pleural cavity or into the mediastinum. That's how somebody ends up with a pneumothorax or the pneumomediastinum. Again, if your patient is not improving, the respiratory rate is not improving, they're still complaining of difficulty in breathing, you've given all the medication you think is correct, look out for these complications, because the respiratory parameters will not change if these complications are in place. Sometimes they can actually get a cardiac arrest. And then lastly, the medication side effects, especially the short-acting beta agonists. Salbutamol causes tachycardia. So sometimes you may be giving your patient the medication and you see that they're actually getting worse. They are feeling much worse. They are crying out of chest pain. It's because the rhythm has gone so high. It's a terrible feeling. Much as you're trying to relieve the obstruction, you're actually having toxicity of the short-acting beta agonists. That's why it's important to keep monitoring these parameters as you give the patient the medication. Antibiotics, should we not? They are not routinely given. They are not necessary for an exacerbation unless there is evidence that this patient has a bacterial infection. So assess the patient, find out if there is a likelihood of a bacterial infection. Maybe they have a pneumonia on top of the exacerbation. That's the only time that you need to give antibiotics. Ensure they are well hydrated, and if they are stable or you are comfortable that now they have taken them out of the exacerbation or they are relieved, they can be managed at home, you need to plan how to discharge them, when to do the follow-up care, usually within 1 to 2 weeks. So quickly, what are the things you need to do? You've decided that the patient is better, you need to go home. This may be on the very day when they came to you, after a few, maybe after the 3 cycles, they are better, and you think they can be managed at home. How do you send them home? It's not just a prescription. So before you send them home, this is an opportunity for you to do a comprehensive assessment for the need for what we call the controller medication or the daily medication. Remember, people go into attacks because they have chronic inflammation. They may have had those symptoms and they actually have the chronic asthma, but this time, the first time they're presented to you, it's an attack. So this is an opportunity for you to actually start them on the controller medication so they don't get repeated attacks and then their lungs can be spared. So if you think that they need the daily medication, start the inhaled corticosteroids at discharge. Do not wait to say when you come back, we shall talk about chronic care. This is an opportunity. Otherwise, the next time you might see them is when they have another attack, and that cycle may continue until you have a catastrophe. Make sure that they continue with the medications at home. Like prednisone, we said you give 2 to 3 days. If you're given the first dose in the clinic, then you instruct them to continue the following day and then the next day. Train them on the inhaler technique. So please make sure that before you send them home, the things you've done for them to use the obstruction, teach them how they can do it at home. It sounds easy, but many times it is the difference between getting a breakthrough and failing altogether. Educate them on the triggers to avoid. We went through them. And then plan to review them within 7 to 14 days. So the follow-up time is usually around that time. But if somebody has had a life-threatening exacerbation or severe exacerbation, we make it much shorter in about 3 to 4 days. So earlier on, I had sent some cases and some information. I'm hoping some people were able to go through them. So I'm not going to go through each one of them in the interest of time. And maybe now I'll take on some questions that were sent to me. Chair, I need your guidance on this. Because this case, I worked it out and we can read it. So Chair, what is the opinion? I thought I would go through the cases, the questions that came through. Some of them I'm sure have been addressed by the presentation, but there are some questions which I would want to go through.
Doctor, you can do it in a way that's convenient for you, because you may find within the cases you are going to present, you may answer some of the questions. So if we could have 2 or 3 cases that you have put on, perhaps that would serve, then we can pick from the questions a few more. We can take another 25 minutes to complete that.
Okay, thank you so much. So I've chosen one case, but it will serve as a learning point, and we can go through the other cases on our own. So the first case that I sent out, this is a 3-year-old boy, comes to you with a runny nose for 2 days, cough for 2 days. The mother says the child has been breathing badly since morning. They noted that it was a little bit hot. And this is the 4th time in 6 months they are coming with such symptoms. While at home, the mother attempted to give amoxicillin, but she noted that there was no improvement. despite that antibiotic. So we want to find out, that's what the mother tells you. What more do you need to ask to guide your management? Again, it is focused questions. It's not the comprehensive history at this point in time. So a few questions you need to ask. Is the child feeding well? Have you had any wheezing? What triggers? Look out for certain triggers. And the other symptoms like I talked about. In this case, the mother said that the child has itchy eyes. After those very few questions, quickly move to examination. I mentioned earlier that we focus on life-saving examinations. So in this case, the child did not have visible cyanosis, but when measured the oxygen saturation, it was 88%. It was certainly low. And what I want to emphasize here, and the need to have a pulse oximetry in every health facility. Not every child who has low oxygen saturation, you can detect the cyanosis on examination. There are some children where they have low oxygen saturation, but you cannot see the cyanosis. So it's very important to have this simple gadget called a pulse oximeter to help you take a decision. The temperature was 37.2 and this child weighed 14 kilograms, was irritable, agitated. The respiratory rate was 66 breaths per minute. This child is 3 years and certainly that is a raised respiratory rate. The pulse rate was 146 beats per minute. It was higher than what it should be. Normal range for this age group, I think, should be around 80 to 120. And when we examined the chest, this child had subcostal and intercostal recession. So from those signs and symptoms, my conclusion when I was grading the severity is that this child had severe acute asthma exacerbation. When you get a time to go through each of these criteria, you'll find out that I used the low oxygen saturation and the presence of use of accessory muscles to put this child at that level of severity. So in my mind, this is severe acute exacerbation. So I asked myself, what do I need to do? I'm at a health center 3 or health center 4. Lucky enough, I have oxygen. So this child needs oxygen. I quickly connect the oxygen using nasal prongs and nasal cannula at 2 liters per minute. I'm targeting to have an oxygen saturation at least around 90 for 95. So I monitor. The moment I put the child on oxygen, I wait for at least 15 minutes to see, 10 to 15 minutes, depending on the guide, to see if I've reached that level of oxygen saturation that I want. Then I start the child on inhaled salbutamol, 3 puffs using a spacer with a mask. So remember when I was giving the presentation, I said 4 to 10 puffs. For the under 5s, we titrate anything between 2 to 4 puffs. So I chose the average of 3 puffs. I used the spacer with a mask because the child is less than 5 years, and I gave 3 doses in 1 hour. But I also remembered that I needed to stop the progression of the inflammation. This child weighs 14 kilograms. The tablets of prednisolone we have are 5 milligrams each, and I'm expected to give 1 to 2 milligrams per kg. So I chose to give 15 milligrams, which translates into 3 tablets. This is in the health facility. So I kept on monitoring and I was happy with the progress. So by the end of the 3rd dose of the salbutamol inhaler, I checked again. And at that point in time, the oxygen saturation has gone up at 97 in room air. So I'm happy that at least the child is getting enough oxygen. The respiratory rate has gone down from 66 to 46, but it is not yet in the normal range, but at least it has markedly improved. The heart rate is now 152. There is no subcostal intercostal recession. If you remember, the heart rate before I started salbutamol was 146. Now it has gone higher, 152. So I'm asking myself, is this child getting worse or not? The answer is that the child is not getting worse. It is because for some individuals, or majority of the individuals, salbutamol makes the heart rate go higher, but it is temporary. That's why it is important to keep monitoring. If it goes high, it keeps going higher and higher, reaching severe tachycardia, then that's a problem. But otherwise, sometimes you expect the heart rate to go up but it is a temporary. Usually it goes back to normal within 5 to 10 minutes. So I'm not worried about this heart rate. I'm going to check it again in 10 minutes and see what it is. So the respiratory rate is still high, but not as bad as it was. There is no intercostal recession. The oxygen saturation is fine. What is my grading at the end of the 3 doses? From those signs and symptoms put together, now the child has mild exacerbation. After intervening, the child is much better. I can comfortably now start the instructions of sending them home. We do not admit mild exacerbation. For moderate, severe, and life-threatening, certainly you want to keep them around, you want to admit them. But if they have mild signs, then you can start to plan the discharge. So remember, the mother said, this is the 4th time in 6 months. I am not comfortable sending this child after this treatment without doing a comprehensive assessment. So I assessed this child for possible asthma. We shall talk about that another time, what I need to go through, because the subject of this topic is really acute care, but please make sure that you assess for possible asthma so that you can start the controllers if required. Then I'll discharge this child on salbutamol inhaler to continue at home, 3 puffs every 6 to 8 hours for at least 3 days. So the reason why we do this, it is not uncommon for you to relieve the obstruction. Like a child could come to you at 10 a.m., you do the right thing, and in the evening they are back. Because sometimes that obstruction is kind of relieved and then it keeps coming back and something like that. So we tend to give at least 3 days. We are usually sure that within that 3 days, the inflammation has gone down. And so we don't have any more worries about obstruction coming on and off again. They will continue with prednisolone, 15 milligrams once a day for the next 2 days because I gave the first dose in the clinic. And from my comprehensive assessment, I noted that this child needed the controller medication. So I take this opportunity to start inhaled beclomethasone or whatever inhaled corticosteroid you have in your health facility. So for this child who is 3 years, I start 50 micrograms twice a day until I see them the next time. I train the mother on how to use the bottle spacer, how to make it and how to use it, because most of these spacers that are scientific are not available, but at least I know how to make it. So I teach her how she can reach home and make a bottle spacer or the plastic cup spacer and how to use it at home. I educate her on trigger avoidance, and then I plan within 7 days to review this child. One of the things we always want to do at the point of review, we tell them to come with all their medications. This is an opportunity to review the inhaler technique, to review the kind of medicine they are giving. It's not uncommon for them to interchange and give salbutamol daily instead of the inhaled corticosteroid. So this looking at whatever they are doing and them demonstrating to you helps you to know they're actually doing the right thing. So that is the case. The others, we can go through them, but maybe at this point in time, I'll respond to some of the questions that came through, as later on, maybe I'll look at the chat. Most of the questions, I believe, they have been answered, but there are some key ones. Can neonates also get asthma? I've not come across any neonate, but maybe just to emphasize that it's usually not easy to diagnose asthma in children less than 5 years. But if you're keen, and especially if they're having these recurrent symptoms, you can actually come to a conclusion that this child has asthma. You try them on the medications I've described, and you'll see a great improvement. But neonates, unlikely, especially people who are less than 6 months, it's unlikely. So for such cases, I think you need to look out for other possible causes of those symptoms, or send to a specialist to have another look. What is the role of the nurse in managing an exacerbation? In most of our health facilities, we have nurses actually doing clinical care. So please, when a child comes to you, when an adolescent comes to you, we've gone through this talk, do something to save that life. I imagine even if you have a doctor on call, or you have a specialist and they're not readily available, there is something you can do to save that life. So The role of the nurse is clear. You can monitor the oxygen saturation. You can give the nebulizer if indicated. You can help the mother give the inhaled medication. So there is a lot that you can do. What is the latest magic drug in treatment of asthma? In terms of exacerbation, it's not latest. It has been here with us all the time. But we've just been using the oral route. The inhaled medication is the magic around managing the exacerbation. How appropriate are tablets, Montelukast and syrup ascoril in pediatric asthma? Montelukast is a controller medication. I will not comment about it now. We don't use it in exacerbations. Now, ascoril contains salbutamol. It's a syrup, but it contains other components. So like I mentioned, oral medications are not good in managing exacerbations, and that's why we are phasing them out and prioritizing the inhaled medications. Any current herbal remedies for asthmatics? I know none, but I know that there is a lot of herbal research that is going on to try and see if there are any herbal medications. Remember that salbutamol was first extracted from a herb in China. So we know that most of these medications we have, their origin is actually people studying herbs, and we are hoping at some point we shall be able to have these herbs, and it will be much cheaper for us. Rationale of using adrenaline in management of acute exacerbation, a very good question. Previously, when I was still in medical school so many years ago, we used to use adrenaline. But as you noted in the cascade of care, I did not mention adrenaline. So the recommendation is that if you do not have, for example, inhaled medication, you don't have the nebulized medication, you're really pushed to the wall. That's the only time you could try out adrenaline. But remember, number one, it's very difficult to measure the doses, especially for children. The technique of giving, it should be subcutaneous, but it also affects the heart. So you may end up in a catastrophe instead of saving the patient. So it is not something that I would recommend to reach out for. I would rather that we try everything possible to have some of these inhalers in our health facilities, and we can use them. One canister of an inhaler is 120 doses, and it can save so many lives when they keep coming to a health facility. As the parents try to go and buy, at least you will have saved them for the first time. The other question, what is the role of labs in relation to this topic of acute exacerbation? So like you saw, apart from doing pulse oximetry, which is a lung function test, other tests can only be done if they're indicated. For example, if you think the child has a bacterial pneumonia and maybe has signs of a consolidation, then you could order a chest X-ray. Otherwise, there are no routine labs in an acute exacerbation. So do not waste those resources, do not waste time. It is about the obstruction, it's about oxygen delivery, relieve the obstruction, stop the progression of the inflammation, and then after there you can settle and see what else you need to do differently. Can we give inhalers in kids? I think I've just answered that. Please use the inhalers. A very important question, resistance to salbutamol. Is that why there is a shift to use of aminophylline? So I want to explain why some people will not respond to the salbutamol. So if somebody has repeated attacks, but these attacks are not being prevented by daily medication, what we call the controllers, it means they are going to go on having the chronic inflammation, and at some point they'll have airway remodeling. So those people, because they concentrate on using the inhaled salbutamol, I've met people who they say, for me, my magic drug is salbutamol. So every time they get an attack, they pull out the salbutamol, and it feels good. They rely on it. But the problem is that they are not preventing. We shall discuss that concept maybe when we get another time, but it's very important to use inhaled corticosteroids because they prevent attacks from coming. So for those people who are on what we call monotherapy, meaning that they're only relieving all the time they get an attack, it will reach a time when the airway gets fixed In other words, there is fixed obstruction to an extent that when they use the salbutamol, they no longer feel the magic that they used to feel. So it's very important that when they come in an exacerbation for the first time, assess for the need to get controllers and start them so that you can prevent future exacerbation and therefore dependency on the salbutamol. Lastly, the link between asthma and epilepsy. I think it's important to find out if it's epilepsy you're dealing with, because there are some people who actually collapse when they're having attacks. It may be because they have had the oxygen saturation going so low, but I've met adolescents where they say that every time they get an attack, they have so much fear and anxiety that they're going to die. And so that state could actually make them collapse. But when you do the vitals, they're actually okay. So try to find out, are they talking about epilepsy or it's the issues that are associated with the attack itself? I think I'll leave it at this. I've answered most of the questions, I believe. Now, let me check the chat quickly. Quite a number. I'll send the slides to the management so that we can look up, or we can have an opportunity to use those slides to answer those questions. Yes, Dr. Mkembo, you're saying something, please?
Yeah.
Sorry?
Yes, Doctor, you have answered the majority of the questions that were on the chat, but as you take a sip of water, let me check through if there's any not answered. I mean, you had answered the majority of the questions that were on the chat while you were explaining the presentation. And I'll scroll through, just pick a few as you sip maybe a sip of water. And then there may be a question. I would ask them to raise up their hand. We shall pick you. We'll pick a few questions by hands. I see a question. Someone was asking, when do I use aminophylline or magnesium sulfate and what is their role? This is a question which you rightfully answered. Magnesium sulfate was given. The question was for ICU. Doctor, talk about intravenous salbutamol, if it is still in the guidelines or not, because your previous discussion, it was the third line, but today we have not talked about it. Jackson, did you want to mean intravenous aminophylline or intravenous salbutamol? Yes.
I don't know that it is
a
my
comment on asthma versus reactive airway disease. And that was a question from
I think I'm able to see the chat. Let me answer some of the questions.
Magua.
Okay.
Doctor, are you not picking me? Are you getting me?
Yeah, I had lost you a bit, but let me try to go through the chat also and answer some of the questions. Yes, maybe I might.
Fine, you can go ahead.
Just a time. Yes. So the question about IV salbutamol, the way the current guidelines are designed, especially for primary care settings, is to use those medications that have been proven to be extremely effective, but also safe at that level. IV salbutamol is still an alternative, but it's not something you'd reach out for. And so that's why we don't emphasize it. That's why we don't talk about it, especially when we're talking about primary care in most of our facilities. So it's about the practical things, the available things that we can actually do to save the lives. But it's an alternative, though not really that recommended for use most of the time when the safer alternatives are there. Reactive airways disease. So there's some people who, in their mind, they actually know that this is asthma, but many times we have challenges writing down that diagnosis. But reactive airways is, I think, a pathological description of what is going on in the bronchi. Like I mentioned earlier, the person has chronic inflammation. And that chronic inflammation, even when it gets acute, it is in a response to some triggers. So if, for example, somebody inhales dust and they react to dust, then that is the reactivity that we are talking about. It's kind of an allergic reaction that is going on. That's why people tend to label it reactive airways disease. But we have moved away from labeling it reactive airways disease. Now we call it asthma, because every time you avoid calling it asthma and refer to the pathological diagnosis, many times your plan for care may not be optimal for that patient. So that is the explanation. Then what are the prerequisites for starting a patient on controller medications? This one, hopefully at some point we'll get an opportunity to discuss, because it's also a whole lot of where to start from, which medication, which start, how to monitor. Today's session was specifically on the acute exacerbation. Is there a role of nebulization with hypertonic saline and acute asthma? Number one, the answer is no. Number one, we know that hypertonic saline can actually cause bronchospasms in some patients. We use hypertonic saline in some conditions, and it's still debatable. We've tried it in bronchiolitis, which mimics asthma, especially when you're looking at the little children. And the reason why we use hypertonic saline, and it's not yet proven whether it has added benefit, is because there is this mucus and the mucus plug that are contributing the obstruction in bronchiolitis. And the hypertonic saline makes it thinner and easy to cough out. And there are other effects that it has. But in terms of somebody who has acute asthma, you can actually be making it worse, because we know that it induces bronchospasms. And that's why when we are using hypertonic saline, when we are going to do sputum induction, we pre-medicate with salbutamol. In other words, we kind of prophylactically give salbutamol inhaler. About the asthma COPD overlap, COPD is an adult thing. I'm not going there today, but I know in the physicians, in some cases, you have that overlap. And sometimes what I'll mention, it is because of poorly managed asthma that somebody ends up with fixed airway obstruction and features of chronic obstructive pulmonary disease. I think that's what, there is this good one. I think I should talk about. Talk about low dose opioids and benzodiazepines, anxiolytics in managing anxiety associated with asthma. The reason why that person is anxious, and if you talk to them, they will tell you, they are worried, they can't breathe, they are suffocating. Relieve the obstruction, they will be calm, they will thank you, will not need an anxiolytics. Don't treat the symptom, treat the root cause of that symptom. I think I'll stop here. If there are any questions that have not been answered, maybe at a later date, or I may go, if I get an opportunity to see that chat, I may send in the responses so that they can be shared. But I believe most of the issues that were raised have been addressed.
Thank you, Doctor.
You.
Yes, Doctor. Thank you very much for that feedback. I saw two hands from Mr. Lubogo Brian and Isaac. There was a question from Isaac Kiria. Please, Brian, unmute and ask your question, then Kiria.
Okay, thank you so much for the presentation. Dr. Rebecca, thank you so much for the presentation. I had only 2 questions to ask, but the other 2 were answered. Then, Doctor, you didn't talk about more about the steroids. Because of these young infants, when they have gastritis, and I would like to talk more about steroids in asthma management. Thank you.
Okay, maybe wait for the next question and I answer them at once.
Yes, Kyria, Isaac. Isaac.
Thank you, Doctor, for the presentation. Thank you, Dr. Robert. There is a case that I've come across of an adolescent. He complains every time he has that congestion in his
Unfortunately, I'm not getting
difficult with breathing. When he goes for physical exercises, for example, football, he gets left at the left side of his chest. With all the explanation, could that condition be associated with the am I clear here?
I think I've got it. I've got the basics. Yes, I've got it.
Hello?
Yes.
Isaac
Hello?
is talking from Tanzania. I think his network is not okay.
I've got it. I'll answer it.
Okay.
Okay.
Dr.
All right, thank you.
Isaac and Brian.
So,
Isaac, in case you are not fully explained, you can text in the chat. Your network was not clear. Doctor, you can go ahead.
So steroids. We are talking about acute exacerbations or acute attacks in simple terms. So we use steroids. First of all, the dosing is very important. One of the biggest problems we find is that people give micro doses. You find a 20-kilogram child being given 5 milligrams, 1 tab. It's not going to reduce the progression. And so sometimes they're forced to give several times in a day. And those ones who are not on controllers, they're getting acute attacks every week, every month. They'll be on steroids every now and then. So those are the kind of children who will end up with side effects. Otherwise, for the normal dose of 3 to 5 days max, we do not expect gastritis. Now, sometimes what we have seen, again, children who need to be on daily medication and they are not on it, and therefore they're getting repeated attacks. And every attack, they get steroids being given. So they will eventually develop gastritis. And so as we treat them, we give the asthma medications, but we also give the medication against the gastritis. Otherwise, they usually don't get better. And that's why it is very important to control the symptoms so you don't end up in that state. Otherwise, for this short-term use, in somebody who, for example, is not hungry, you've given them the right way, you don't expect acute gastritis. Then the issue of exercise, he was trying to describe, I think, somebody who goes for football and starts complaining about chest pain. We have what we call exercise-induced symptoms, and that is a very important thing to look out for. Like I mentioned earlier, it could be one of the triggers. And for this patient, the only thing they complain about is chest pain. And if you remember, I said the symptoms of cough, wheezing, chest pain, chest tightness, the feeling of heaviness can occur all together, or it can be a single symptom. So I would assess that patient more comprehensively. And most likely from your description, they get asthma attacks that are induced by exercises. So we manage the attacks, we put them on controllers. We do not tell asthmatics not to exercise. Let children be children. The most important thing is that you control the symptoms so that their lung function can improve. We actually know that exercise is good for the lungs. The only thing we do if we know that this person gets exercise-induced symptoms, we give them 2 puffs of salbutamol before a planned exercise. That helps prevent an attack when they go for exercise. But what we have observed that when you put them on the controller medications and you control that chronic inflammation, they eventually do not even need those 2 puffs. They can do their exercise very well, 90 minutes of football, do their volleyball and everything very well. So that's what I can talk about the issue of exercise and asthma attacks.
Yes, Dr. Rebecca, I kindly request you. I know this question borders between the physicians and the respirologists like you. How do you put a distinction in that issue of Isaac between a person having acute coronary syndrome in the